Alright, this first video that we're going to watch just kind of gives us the updates and kind of goes through a few things. If there is something that you need to know in a video, I'll bring it out afterwards. So I don't want you to worry about every little thing he says, because he says a lot of...
Resuscitation is constantly evolving and improving. In this segment, we'll review the most recent guidelines and recommendations for shock emergencies and pediatric CPR. The first topic addresses the sequence of steps a rescuer should take when providing high-quality pediatric CPR. The 2015 Guidelines Update reaffirms the CAB sequence, compressions, then airway, followed by breathing as the preferred sequence. This is consistent with the adult CPR guidelines. Another key component of high-quality CPR is the depth of chest compressions. For infants and children up to the age of puberty, it's recommended that rescuers compress the chest at least 1/3 the AP diameter of the chest, allowing complete chest recoil after each compression. For infants, this equates to about 1.5 inches or 4 centimeters. For children, the recommended depth of compression is about 2 inches or 5 centimeters. While deep compressions are important, some data show it's possible to compress too deeply. The adult BLS guidelines added a maximum compression depth of no greater than 2.4 inches or 6 centimeters, which should also be followed in average-sized adolescents. The proper chest compression rate is also an important component of high-quality CPR. The recommended rate is 100 to 120 compressions per minute for infants, children, and adolescents. This is consistent with the guidelines for adults as well. If they're available, use feedback devices to monitor the depth and rate of the compressions. Healthcare providers must minimize interruptions in chest compressions. This includes any pauses to deliver ventilations. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. It takes several compressions to build enough pressure to achieve an adequate coronary perfusion pressure necessary to get return of spontaneous circulation, or ROSC. Rapid identification and intervention of shock is an essential component of pediatric resuscitation. The cornerstone of the treatment of hypovolemic shock has been the early, rapid administration of isotonic crystalloids. Early, rapid administration of isotonic crystalloids is also an important component of the early treatment of septic shock. However, treatment should also include an individualized plan for each patient that is based on frequent clinical assessment before, during, and after fluid therapy is given. When caring for children with severe febrile illness in settings with limited access to critical care resources, administration of bolus intravenous fluid should be undertaken with extreme caution. 2 studies demonstrated that excessive fluid boluses caused complications when given to children with severe febrile illness in resource-limited settings. In previous guidelines, the use of atropine was recommended before endotracheal intubation. The recommended dose when atropine is used as pre-medication prior to intubation is now just 0.02 milligrams per kilogram with no minimum dose. Recent studies conflict, however, as to whether atropine prevents bradycardia and other arrhythmias, and there is no evidence to support routine administration of the drug as a pre-medication in emergency intubations. For high-level providers, the use of an invasive hemodynamic monitoring device is sometimes used. If the child who arrests has invasive hemodynamic monitoring devices already in place, it's reasonable to use the measurements from these devices to guide high-quality CPR. Previous guidelines suggested that amiodarone was preferred over lidocaine as drug therapy for the treatment of shock-refractory ventricular fibrillation or pulseless ventricular tachycardia in children. However, recent studies have demonstrated that neither amiodarone nor lidocaine was associated with improved survival to hospital discharge. The new guidelines allow providers to choose either drug for shock-refractory cardiac arrest rhythms. Recent guidelines state that it's reasonable to give epinephrine during cardiac arrest. An adult study found that epinephrine was associated with improved return of spontaneous circulation, or ROSC, and survival to hospital admission, but it did not improve survival to hospital discharge. However, pediatric studies of epinephrine administration during cardiac arrest had too many variables to determine the effect of the epinephrine, and more data is needed. For children who have an underlying cardiac condition and are experiencing an in-hospital cardiac arrest, extracorporeal cardiopulmonary resuscitation, or ECPR, may be considered for patients unresponsive to conventional CPR. However, this procedure should be performed only in a setting where appropriate protocols, expertise, and equipment are available. For children who are comatose in the first several days after in-hospital or out-of-hospital cardiac arrest, temperature should be monitored continuously and fever should be treated aggressively. For comatose children resuscitated from out-of-hospital cardiac arrest, providers should maintain either 5 days of normothermia, defined as 36 to 37.5 degrees Celsius, or 2 days of initial continuous hypothermia, defined as 32 to 34 degrees Celsius, followed by 3 days of normothermia. For children remaining comatose after in-hospital cardiac arrest, there are insufficient data to recommend hypothermia over normothermia. When trying to predict outcomes of a cardiac arrest, multiple factors should be considered. These factors will inform your decision to continue or terminate resuscitative efforts, and will also inform your prognosis about recovery after cardiac arrest. At this time, no single variable identified either during an arrest or following a cardiac arrest predicts outcome with sufficient accuracy. Once ROSC has been achieved for a child, it's recommended that caregivers use inotropes and vasopressors to maintain a systolic blood pressure above the 5th percentile for age of the patient. To maintain this, advanced caregivers should use intra-arterial blood pressure monitoring when possible to continuously assess blood pressure and identify and treat hypotension. This vigilance is important because recent studies have shown that children who experience post-ROSC hypotension have worse survival and neurologic outcome. Another post-ROSC guideline relates to the management of the patient's oxygen. It may be reasonable for rescuers to titrate oxygen administration to achieve normoxemia, which is an oxygen saturation of 94% or above. When possible, oxygen should be weaned to target an oxyhemoglobin saturation within the range of 94 to 99%. The goal should be to strictly avoid hypoxemia. Achieving the appropriate oxygen saturation is associated with improved survival to pediatric intensive care unit discharge. Similarly, ventilation strategies for post-ROSC patients should target an arterial partial pressure of carbon dioxide that's appropriate for each patient while avoiding extremes of hypercapnia or hypocapnia. Adult studies demonstrate worse patient outcomes associated with hypocapnia after ROSC. This concludes our updates for the science of pediatric resuscitation. The American Heart Association would like to thank the following hospitals for providing patient video.
The Children's Hospital of Philadelphia,
Seattle Children's Hospital,
Children's Hospital and Medical Center of Omaha,
Arkansas Children's Hospital.
Okay, so that video is a required video, that's why we watch it, but I realized it bounced all over. We went from BLS to ECMO and atropine, which has been not used now for probably 10 to 15 years. So don't worry about anything in that video. Anything in that video that you need to know will come out later today, and I'll be sure to point it out to you. But it is it's the one that's absolutely required. So now we're going to watch the BLS video really quick. We're just going to review the numbers for BLS and how to do those. So that won't take us very long.
Sudden cardiac arrest occurs without warning or within just a few minutes after symptoms appear. On any given day and at any time, you can encounter a victim with cardiac arrest. And with the training you receive today, your actions can give the victim the best chance of survival. But first, let's talk about the chain of survival. There are 5 links in this chain. The first link in the pediatric chain of survival is prevention of arrest through injury prevention and through treatment of respiratory failure and shock before these conditions can lead to cardiac arrest. The second link is immediate recognition of cardiac arrest and provision of immediate, high-quality bystander CPR. Both compressions and breaths are important for most pediatric cardiac arrest. Next comes rapid activation of the emergency response system, followed by effective advanced life support, with the final link being integrated post-cardiac arrest care. This chain is a useful metaphor to understand the connection and flow between the stages of emergency cardiovascular care. You never know what situation you'll face or what resources will be available, but our goal is that with today's training, you'll have the knowledge and a framework to provide high-quality, life-saving CPR, regardless of the conditions and circumstances. To begin training, we'll focus on individual skills that rescuers perform. It's most effective to perform CPR as a team. However, to be an effective team member, you'll need to possess the individual skills of CPR. So we'll start there. As a healthcare provider, your first step is to assess the surroundings for safety. Then tap and shout to determine responsiveness.
Hey, are you okay? Are you okay?
If there's no response, you should shout for nearby help or activate the emergency response system in your workplace.
Activate the emergency response and get an AED.
Check a carotid pulse. Locate the child's trachea by using 2 or 3 fingers, and then slide your fingers into the groove just to one side of the trachea where you can feel the carotid pulse. The technique of feeling for the carotid pulse is usually easy to perform on the side closest to you, the rescuer. Check for breathing by scanning the victim's chest, looking for chest rise. You can scan for breathing and check a pulse simultaneously to minimize time before first compression. The check for breathing and pulse should take at least 5, but no more than 10 seconds. If you observe no breathing or only gasping, and you do not feel a pulse within 10 seconds, start CPR immediately. A bit later in this course, we'll talk about what to do if someone is unresponsive, not breathing, but does have a pulse. But right now, we're assuming you don't feel a pulse, so compressions are needed. By starting compressions, you're initiating the CAB sequence, or compressions, airway, and breathing sequence. After you give compressions, open the child's airway and deliver breaths. It's important to minimize interruptions in chest compressions to less than 10 seconds. Each time you stop compressions, the blood flow to the heart and brain decreases significantly. Once you resume compressions, it takes several compressions to increase blood flow to the heart and brain back to the same levels. So any interruption in chest compressions can result in low blood flow and minimize the chance of return of spontaneous circulation, or ROSC. Breaths should be given with a barrier device, such as a pocket mask or face shield, during one rescuer CPR. The device used should be similar to what the students will be using in their workplace. If the type of device is unknown, instructors should provide students with the device they use in training. In some circumstances, a workplace may have only a bag mask device available. In these instances, students may complete their skills test with a bag mask device. In the clinical setting, a rescuer may not be able to deliver 2 breaths within 10 seconds when using a bag mask device during one rescuer CPR. The American Heart Association BLS guidelines define anyone from age 1 year to puberty as a child. Under these guidelines, puberty is defined as chest or underarm hair on boys and any breast development on girls. When you're performing compressions on a child, it's fine to use 1 or 2 hands, whichever works for you and allows you to provide deep, effective compressions. To be effective, your compressions must go to a depth of at least 1/3 the depth of the child's chest. That's about 2 inches or 5 centimeters. And the chest must recoil completely between compressions. With single rescuer CPR, always use a compression to ventilation ratio of 30 compressions to 2 breaths. However, when performing 2 rescuer CPR and the victim is a child, the ratio changes and should be 15 compressions to 2 breaths. Before we start, you need to make sure the child is on a firm, flat surface, lying face up. If you need to remove any clothing from the front of the child's chest, do it quickly. You'll need to work with a bare chest, and later you'll attach the AED pads to bare skin. To begin, place the heel of one hand on the center of your mannequin's bare chest over the lower half of the breastbone. Place the heel of your other hand on top of the first. Make sure that your shoulders are directly over your hands with your elbows straight. And when we start, remember to push straight down on the breastbone to get adequate depth. When you push, push hard and fast. You can follow along with what's on the screen as you perform the compressions yourself. You'll perform 3 sets of 30 compressions. And remember, we'll be performing compressions at a rate between 100 and 120 per minute while counting them out loud, making sure the compressions are about 2 inches or 5 centimeters deep, allowing the chest to recoil after each compression. Okay, let's go. 3.
Good job.
The bag mask device consists of a ventilation bag and a face mask, and it comes in a variety of sizes. You can also use supplementary oxygen with the bag mask device. To begin, position yourself directly above the child's head. You'll use the EC clamp technique to hold the mask in place. To do this, place the mask on the child's face, using the bridge of the nose as a guide. Use the thumb and index finger of one hand to make a C to press the edges of the mask to the face. The remaining 3 fingers of your hand should form an E to tilt the head back, lift the jaw, and open the airway. Make sure you squeeze the mask with your thumb and index finger while lifting the jaw to achieve an airtight seal between the mask and the face. And squeeze the bag with your other hand. If the chest does not rise with each breath, then you're not providing adequate breaths. But if this occurs, readjust the mask, reposition the head and neck, and attempt to ventilate. And then, only if necessary, administer a larger amount of air. Make sure to deliver each breath over 1 second with just enough volume to make the chest rise. Delivering breaths in this way will reduce the chance of gastric inflation, or air going into the child's stomach instead of his or her lungs. Gastric inflation can cause vomiting and possible aspiration. If you have multiple rescuers, the most effective way to deliver breaths with a bag mask device is to use the 2-person technique. One rescuer focuses on keeping the airway open and securing the mask, while a second rescuer squeezes the bag to deliver breaths just enough to cause chest rise. The first rescuer will use both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C to seal the mask against the face, and the 3 remaining fingers of each hand will form an E, lifting both sides of the jaw into the mask. Be careful not to press too hard on the mask, which could push the patient's jaw down and block the airway. Another way to deliver breaths is with an advanced airway. Devices such as a laryngeal mask airway, supraglottic airway device, and endotracheal tube are types of advanced airways for providing breaths. These devices help prevent gastric distension and airway obstruction. Placing these devices requires special training that we will not cover in this course, but you should know how to give breaths with an advanced airway in place. During CPR, when one of these advanced airways is in place, the ratio of compressions to breaths changes. Instead of giving 30 compressions and 2 breaths, you'll perform continual compressions at a rate of 100 to 120 per minute and give 1 breath every 6 seconds. There are no pauses in compressions to give breaths with an advanced airway, which allows blood flow to the heart and brain to remain high. Now it's time to practice the 1 rescuer bag mask technique. We'll pause here to get into position. Now that we're ready, let's practice using the bag mask device.
Good job.
Here we go. In 3, now let's focus on the use of an AED. You'll be familiarizing yourself with the AED device that you'll use today for your training class. There are some differences for the use of an AED for infants and children under 8. Some AEDs can deliver either an adult or child shock dose. The child dose is used in children under 8. If you're using a pediatric-capable AED, it will have features allowing a child-appropriate shock. But which feature is available depends on the type of AED you're using. Your AED may also include smaller-sized pads that are designed for children under 8 years of age. If it does, use them. If not, use the adult pads while making sure that they don't touch or overlap. However, you should never use the child pads for an adult. The shock dose delivered by child pads is too small for an adult and will likely not be successful. It's better to provide high-quality CPR than attempt to shock an adult victim with child pads. Some AED pads recommend a different pad placement for infants and children, placing one pad on the chest and one pad on the back. Follow the pictures on the pad packages for proper pad placement. Although AEDs may differ slightly, there are 4 universal steps for operation: turning on the AED, attaching the pads to the patient, analyzing the heart rhythm, and delivering a shock if indicated. To begin, turn on the AED. Just open the carrying case or the top of the unit and simply power on the AED. Some devices will power on automatically when you open the lid. After that, attach the pads to the victim's chest by using the diagrams on the pads for correct placement. Some AEDs may have adult and pediatric pads. Be sure to use the adult pads on anyone 8 years of age or older. If you're not sure of the child's age, use the adult pads. You may also need to plug in the pads for certain models. Following the pictures found on the pads, attach the adhesive pads to the victim's bare chest. Place one pad on the child's upper right chest directly below the collarbone, and the other to the side of the left nipple.
Plug in pad.
After the AED is turned on, some units will tell you to press a button for the device to analyze the heart rhythm. Others will analyze the rhythm automatically. The AED may take about 5 to 15 seconds to analyze the rhythm. The AED will deliver an audible prompt when it's ready to analyze the rhythm, followed by a prompt to clear the victim.
Analyzing rhythm. Do not touch the victim.
Clear.
The rescuer should strongly repeat the command to clear, checking visually to be sure that all rescuers and bystanders receive the command. Once the AED completes its analysis, if a shock is advised, it will charge and then prompt again to clear the victim.
Shock advised. Charging. Do not touch victim.
Clear.
The rescuer should again repeat the clear command to those nearby and visually confirm no one is touching the child, not even the person in charge of giving breaths. Then the shock can be delivered.
Push the shock button now.
Next, press the shock button. The shock may produce a sudden contraction in the victim's muscles.
Push the shock button now. Shock delivered. Resume chest compression.
1, 2, 3, 4, 5. After the AED gives the shock, resume CPR immediately, beginning with chest compressions. Do not remove the AED or turn it off. The device will repeat the analyze and shock cycle about every 2 minutes. Follow the voice prompts of the AED. If at any time the AED indicates no shock is advised, immediately start chest compressions. If the child has water on his or her chest, this can be a problem. It could allow the shock to travel through the water between the pads, ultimately preventing delivery of an effective shock dose to the victim's heart. If someone is lying in water, you should quickly move the victim to a dry area. However, if the victim is lying on snow or in a small puddle, you may use the AED. And if the chest is covered with water or sweat, wipe the chest before attaching the AED pads. But wipe the chest quickly. It doesn't have to be completely dry. We'll pause here to allow you to get familiar with the AED in your class today. Your instructor will show you all that's included in the kit and demonstrate the correct way to place the pads on the victim. There are some differences in sequence for the lone rescuer of a child, depending on whether the child was found in arrest or the arrest was sudden and witnessed. If you do not witness the arrest and are alone and have no mobile phone, you should shout for help, but perform 5 cycles of CPR before you leave the child to activate the emergency response system and get a nearby AED. Then return to the child to perform CPR and use the AED. However, if you are alone without a mobile phone and you do witness a child suddenly collapse, you should leave the child to quickly activate the emergency response system and get a nearby AED, Then return to the child to perform CPR and use the AED. Of course, when there are multiple rescuers, the first rescuer should remain with the child to begin CPR, while other rescuers activate the emergency response system and retrieve the AED. Now you're ready for your instructor to evaluate your skills performance. Now, we'll talk about the skills for 1 and 2 rescuer infant CPR. But this time, we'll first learn to check for a brachial pulse, followed by infant compressions, and then we'll go on to breaths with the bag mask device. Finally, we'll combine those for practicing 2 rescuer infant CPR. To check an infant's brachial pulse, first, place 2 or 3 fingers on the inside of the upper arm, between the elbow and shoulder. Then, when attempting to feel the pulse, press the index and the middle fingers gently on the inside of the upper arm for at least 5 seconds, and no more than 10 seconds. If there is no pulse, or if the heart rate in an infant or child is less than 60 beats per minute, with signs of poor perfusion despite adequate oxygenation and ventilation, begin compressions with the ventilation. To begin CPR, place the tips of your 2 fingers on the sternum or breastbone in the center of the infant's chest, just below the nipple line. But be careful not to press on the bottom of the breastbone. With that correct position, push hard and fast to a depth of at least 1/3 the depth of the chest, or about 1.5 inches or 4 centimeters. And the rate needs to be 100 to 120 compressions per minute. After each compression, allow the chest to recoil completely. So, let's get in a position to practice compressions. Okay, let's go. In 3, 2, 1.
Good job. We will actually practice, but we're just not going to get up and down.
Now it's time to practice 2 rescuer infant CPR. But before we do, let's take note of a couple differences between 1 and 2 rescuer infant CPR. One difference in 2 rescuer CPR is the technique for giving compressions regarding your hand and finger placement. When you do 2 rescuer CPR, the person doing compressions should use the 2 thumb encircling hands technique. Here are the steps. Place both thumbs side by side in the center of the infant's chest on the lower half of the breastbone. There should be no pressure placed on the tip of the breastbone, and your thumbs may overlap in very small infants. Then, encircle the infant's chest and support the infant's back with the fingers of both hands. In this position, use both thumbs to depress the breastbone at least 1/3 the depth of the infant's chest, or about 1.5 inches or 4 centimeters. The other key difference that we've mentioned is the compression to ventilation ratio. As we mentioned before, instead of a 30-to-2 ratio in a 1 rescuer situation, you'll use the ratio of 15 compressions to 2 breaths. So, let's practice our compressions for 2 rescuer CPR. As a reminder, make sure your rate is between 100 and 120 compressions per minute. Use the 15-to-2 compression to ventilation ratio because you have 2 rescuers. Make the compressions at least 1/3 the depth of the chest, or about 1.5 inches or 4 centimeters. Allow the chest to fully recoil with each compression and count out loud for your partner. Now it's time to practice infant compressions. We'll pause here to give you a moment to get into position with the mannequins.
Okay. Let's just bring out the high points to remind ourselves. What's our rate for all compressions?
100 to 120.
Okay. And for infants, for infants and children, for 1 rescuer CPR, how many compressions per breath?
30 to 2.
30 to 2. And for 2 rescuer? 15 to 2.
2.
When I do my pulse check, how long should that last?
5 to 10
5
seconds.
to 10 seconds. At least 5, no more than 10. I'm going to start CPR if ventilation doesn't help and the rate is below 60, especially in the infant. When I'm doing CPR, it's very important to know all the effective elements. One is the depth, one is the rate, one is the ratio, the other is that I need complete recoil. So if you were asked that question later today, what's an effective element of CPR? I would say maybe complete recoil is an effective element of CPR. That's what I would say. The other thing that's kind of important is the sequence. In adults, it's always go call 911, get the AED. With a child, if it is unwitnessed, we are going to do 2 minutes of CPR before we go get help. If we are alone and we don't have a mobile phone. If we're with somebody, they go get help. And if we do witness it, did I say that right? If it's unwitnessed, we're going to start and then go. If we witness it, we're going to leave the child and go call 911. That's also an important piece of information. So the way we're going to do this, we're going to break up into groups. There'll be 2, 2, and 3. But we're going to do the child first. All 3 groups can go at the same time. Jill and I can watch multiple groups. The first person who comes up, Jimmy, are you okay? Somebody call 911 and get the AED. No pulse. I'm going to start 27, 28, 29, 30. See, I said there was a time-space continuum. 1, 2, 1, and 2, and 3. The second person cannot arrive with the AED until you've done a cycle or 2. Then they arrive, don't actually stick the pads to, but go through the motions of opening it, laying the pads on. And then when it's done delivering its shock, the person who brought the AED, always the second person starts compressions because the first person's tired. I mean, we're only going to do a couple cycles here, but if you're actually doing them, you know it's very tiring. So I just want the second person to start, and then the first person will deliver breaths. When you get to that point, I'm going to say tap out, switch positions. You're going to pack it up, and the first person is going to say, Jimmy, or the second person is going to be, Jimmy, are you okay? Go call 911 and get the AED. We're just going to go through it like that. We're not going to do 5 cycles. I just want to see good compressions, and I want to see a couple of good breaths. For everybody has to be checked off on airway management, infant, and child. There's an AED. We'll set up 1 more station back there so that we'll have 3 stations. So there's an AED and a bag at every station. This, if you don't like this table, because it's kind of, you're welcome. There's some mats over there. I'm happy to get them out and we can use the floor if the team who has this table would prefer not to have it. I just didn't know how people would feel about the floor. One of our AEDs has a low battery, so if you have the one that has low battery, if it says low battery, just turn it off and say, analyzing heart rhythm, and be the AED. We're not going to get too fancy. You all had to take BLS to get here, but the American Heart is just requiring us to review it every time with every class. And it's kind of important because if you don't do it, it's not second nature. Okay. Let's start the child.
Jimmy, are you okay? Go get help.
Call 911. Get the AED. Call and get help. Go get the AED. Starting CPR. A bit deeper than 10.
Oh, sorry. Yeah, sorry.
There we go. 28, 29, 30. Yeah.
30. Yeah, okay. Just say 28, 29, 30.
There we go.
Okay. Okay. Go ahead and attach a while he's doing this.
Bypass the patient's spare chest. Plug in PALS connector, analyzing heart rhythm. Bypass the patient's spare chest. Plug in PALS connector, analyzing shock device. Charging, touch the patient. Stay clear of patient. Deliver shock device. Press the orange button. Shock delivered. Stay clear of patient. Again, pass the patient with bare chest. Press the orange. Plug in PALS connector. Next to flash shock delivered. Begin CPR.
It's not plugged in, so it's not
Plug in
going to
connector.
get plugged in. All right, you tap it out, and we'll start the other way. Tap it out.
Yep. 2 minutes past. Okay. What did you start like that? Analyzing heart rhythm.
Analyzing heart rhythm. Do not touch the face. Press pads firmly to patient's bare chest.
Yeah, somebody mentioned something about it to me, like I was just afraid I didn't start in the conversation. That's fine.
Analyzing heart rhythm. Do not touch the patient.
Analyzing.
This AED is slow.
Okay, it's ready to deliver a shot.
Shock advised.
Shot out.
Well,
Stay clear of patient.
visuals, you're already good.
The shock delivered.
Shock delivery.
Pause. Begin CPR.
Okay. Yeah, I know. That's an important point to bring out. These AEDs say to pause after the shock, and we don't pause after a shock. As soon as we shock, we start chest compression. All right, tap out. Let's do the other way.
All right, just like everything back. Turn. I know the past totally threw me off.
I know it's AED waits forever to analyze.
Alright, I'm here, buddy.
Johnny, are you okay? Jimmy.
I'm just
I'm super teasing you. Are you okay? Give AED, please call 911. Okay.
Apply pads to patient's bare chest. Plug in pads connector, analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock delivered. Pause.
But when you get there with the AED. The first thing that happens is the AED. No, I brought it. I told her I brought it. But you want me to open it? So what happens is when the second person comes, the second person does the AED. The first person continues. Okay, guys, thanks.
There's the silver lining. Yeah.
I'm just gonna walk through it. I think we're right here.
All right, ladies, let's do
Analyzing heart rhythm. Do not touch the patient. Press pads firmly to patient's bare chest.
Remember to switch when you're by yourself.
Are we doing?
Yeah.
I guess we're doing infants.
No, AED. I want to see the full 30 and then.
Analyzing heart rhythm.
So I'll tell you when you're
Do
somewhere.
not touch the patient.
Baby, are you okay? Hi, baby. Okay.
Shock advised. Charging.
You guys are good.
Stay clear of patient.
So then we only have 2 babies, so we'll just.
Deliver shock now. Shock delivered.
Please go get the
Pause.
I'll call for them. So you go then.
Begin CPR.
Okay.
Going to get help after they get emergency response.
All right. We only have 2. So, all right. That there's real life.
Yeah.
Especially with a baby. Did you do 30?
Yes.
I know these guys in here. Okay, that sounds great.
Replace pads.
Okay.
It's talking to me.
From the zippered up box comes this.
It's talking to me.
Are you bringing the AED? Did you ask for help yet?
And you don't have to do the AED with the baby, just do your concussion.
Yeah, you know, I'll put it on, just so that you're there.
Baby, are you okay?
Baby, are you okay?
Switch. After this next cycle, I guess.
that's 2 seconds, or that's 2 minutes from now.
She's walking slowly. She's not talking. It's the beginning. It's just man don't want me. Okay, you can get there when she gives her breath. Hi, do you need help with CPR? Sure. Great. And watch yourself, Rachel.
Okay, so you're good. Now you're gonna come. Oh, I found a baby that's down, and one of you can come over and be like the assistant. So he's coming to the scene. He's alone. You're just
Baby.
Baby, are you okay?
okay.
Oh,
Go get help.
Okay.
Go get help. Okay, can I get help?
You did make the neighbor.
Okay.
That's what you need.
Yeah.
I'm here to help. Back. I got the AP, clean it up. Okay. 2, 3, 4, 5, 6, 7, 8, 9, 10.
Oh, yeah. If I go to two restrooms. I think you're 14, 15. There you go. It's 15 to 2 babies. Well, and children with 2. 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6.
CPR with AED, and one is airway management. We just completed them all. If you put your names at the top of them, front and back, if there's a back, for me, then during your test I'll fill out the pertinent information. So the back one is number 3.
Oh, gotcha, sorry.
1, 2, 3. Yeah, it's confusing. Did you put your name on them? Yep, those are them. Yep, just name front and back, and that way I'll just put all the appropriate check marks and initials on it while you're testing. Thank you. Thanks.
No, because you're right, the last one.
I can usually do something really stupid, like I'll be good to do whatever, but like in March I'll start writing.
I did that on my rent check. It's in my rent check. I was like, was any other checks? He's like, why? He's like, this one's what? He goes, yeah, it's 2018. I'm like, whoops. My bad.
In your packet, those of you who just returned, you have these 3 check sheets. That's what we just completed. If you put your name at the top of them, you've got them in your hands right there. They're 2 pages, 3 sheets. Put your name at the top of all of them, and then I'll put all the appropriate check marks on during testing later.
The airway management one.
Yeah, that's what they did by demonstrating their bag valve management. Just while I was got everybody, there's a couple things that I saw. Number 1, it's a real thing. When people are excited with the pediatric code, we tend to give compressions at the rate of about 300. So remember to slow it down. It's not really kosher to sing songs in the resuscitation room, but if you can keep staying alive or something like that in the back of your head, that's about the right rate. We saw a lot of that. And then remember, with children, with babies, it's the brachial pulse, which is above that elbow. And then when there's 1 of you, it's one-handed compressions, and when there's 2 of you, it's 2-handed. This is far more effective. The only other thing I really saw as I watched is really be careful with kids. If you get down on their xiphoid process, you'll lacerate their liver. So it's really important to stay up right there. We say if you just find the nipples and come straight across, it's actually 1 finger width below that we want. So come across with all 3 and then lift up that 3rd one. So those are important things. Thanks. Appreciate it. I have to sit and check mark all these things, so I like to have them all done. All right, I think I covered all the important parts of BLS. Anybody have any burning questions about BLS? So the next thing that we're going to cover is how we assess children. Assessing children takes a little bit different tack than it does with adults. It has three components, the assessment of children. So the very first component, I had a handout that I gave you all that's called the Pediatric Assessment Triangle. This was developed by pre-hospital providers and ER docs. The paramedics are the one who really brought it into the world. PALS does teach it, but they don't really dive in. And I have found that this right here, if you take care of children infrequently, if you can learn this triangle, you will know when you have a sick kid. That's what's important. The problem with children is not what to do, it's recognizing they're sick. Because adults do this. They go downhill. Children go and then they jump off a cliff, just like that. They're fine, they're fine, they're fine, they're fine, they're not. And it's very fast. What we don't really pay attention to, these things we're going to go over, those are subtle signs that are there. And if you notice them, then you'll recognize long before they jump off the cliff. So when you look at the ABCs of the triangle, it's different from our other ABCs. The A does not stand for airway anymore. In this case, it stands for the general appearance of the child. Well, that's kind of a vague thing. She's cute. That's her appearance. I mean, she looks tired. That doesn't help me. So what we do is we tickle our children. If you look down the side there, you have tickles. And tickles are what we do. This is what we determine is the child's general appearance. So the first thing that we're going to look at is tone. All right? A 6-week-old infant should not be floppy. How many times have you taken a 6-week-old infant's arm and pulled it and it does this, right? I mean, they're tight, they're toned, their legs are drawn up. A 2-year-old should not be slumped against the parents. 2-year-olds have some tone. Even a 14-year-old has muscle tone. The other thing is they can have too much tone, right? Seizing, that's a lot of tone. Or sometimes our babies with calcium problems will have a lot of extra tone. But we're looking to see that the tone is age appropriate. If I have a 2-week-old sleeping infant, I'm not really concerned if they don't have super great tone. They'll still have some if I pull on their arm. But a really flaccid child is important. It is a problem. So the first one is tone, and then the I stands for interactivity. Okay? If you can see a 2-year-old in your triage bay that's not watching everything you do like this, you've got a problem. 2-year-olds watch everything. They don't trust anybody. They're watching you. They don't know what you're about to do. They're interacting with their environment. Even a disinterested 12-year-old is watching things. They're interacting with their environment. If you have a kid who's got the 1,000-yard stare, kind of looking beyond you just a little bit, they're not really interacting, or they're focusing so much on the way they feel that they're just not. They don't recognize their caregiver, that sort of thing. That's a problem. The next letter is in our tickles is C, which is consolability. Almost every child, regardless of how much pain they're in, regardless of what the underlying problem is, can be consoled to a certain degree by their primary caregiver. Am I saying that you can take a child with a nasty broken arm and make them calm? Maybe not. Maybe. But they are consolable to some degree. A truly inconsolable, especially infant, is a worrisome sign. True inconsolability usually means we've got some sort of meningeal irritability going on. So we need to make that. So tone, interactivity, consolability, then L stands for look or gaze. Do they recognize items when you hand them to them? Do they seem to really see? Or do they have the 1,000-yard stare? Are they following and tracking items? Or are they just not focusing? So that's what we're looking for there. And then the last is speech or cry. If you've ever heard a meningeal baby, a baby with a meningitis or encephalitis or a head injury from shaken baby syndrome, where they've got bleeding in the meninges, they have this cry. It's very special. It finds the C7 nerve where it exits your neck and makes it do this. It's high-pitched, it hurts, and it's concerning. It's not in relationship usually to stimuli, although sometimes they're very irritable. Just touching them will make them do that cry. Near drownings have that cry when they've got cerebral edema. And the parents are like, oh good, he's crying. And you're standing there going, oh, this is not going to go well. So those are the 5 elements of tickles. So what we decide on every leg of our triangle, starting with the appearance, is it normal or abnormal? So if I have a child who's got an abnormal appearance, I mark that leg of my triangle as broken. It's not right. And then I move on. Oh, it should be blue. I don't know why it should be blue, because I want it to be blue. The B in this case is going to be the work of breathing. So I didn't say it, but this assessment is done from across the room. This is not an assessment where you're touching your child. You're sitting across the room there in mom's lap or whatever, and you're naked. I am not wanting to really know an actual rate here. I just want to kind of look. Too fast, too slow? Are they working to breathe? Do they have retractions? Remember, retractions start low and move high. The higher your retractions are in a child, the greater their work of breathing is. Nasal flaring. What if I hear this from across the room? Bad sign. That's grunting. Sometimes you can hear wheezing from across the room. You can hear this with every breath, and you know exactly where you're going, right? Tachydrawn, racemic epi. You know what you're going to do, but we're listening for that. We're also looking for a position of preference. I remember flying to a small hospital in outside Tulsa, Oklahoma, where they had an 18-month-old who came in. She was laying in grandma's arms, and every time mom would have, she's laying in grandma's arms, so like belly to belly, and her head is to the side. And as long as she's laying there, she looks like there's nothing wrong. I'm like, why are we here flying this child? She looks great. Mom approaches the bed to pick her up, and she turns her head away because she wants to be with grandma. As soon as she turns her head away, she stops breathing. Yeah, she had a bead sitting on her vocal cords that every time she turned, flopped over and included her airway. Very unstable child. I'm not messing with you. But she had a position of preference. She wasn't interacting like a normal 18-month-old with the environment because she knew if she moved, she quit breathing. You'll also find your asthmatics doing this, right? Trying to make that chest cavity as big as they can. Your kids who are drooling, you know, drooling's not cute after age about, 2.5? So you have a 3.5-year-old that's drooling. We take note of that. The maximum position of an open airway in a child is what we call the sniffing position. So if I held out a rose to you, you would just jut your chin out a little. And that's the maximum open airway. So if you've got a kid sitting in mom or dad's lap and that's all they're willing to do, is sit there like that really still. They've got a position of preference. So we're going to take note of all those parts of breathing, and we're going to decide, is it normal or abnormal? And if it's abnormal, we're going to check that leg of the triangle is broken. Okay? And then the final leg of our triangle is the circulation to the skin. This is the first time where we have to touch a child. What do we want to know? We want to know what their capillary refill is. That's really what we want to know. So we're looking for cyanosis, modeling, prolonged capillary refill. What's a normal capillary refill?
Less than 3.
Less than 3. 2 to 3 seconds. The book says 2, 3. Yeah. This is what it's not. 1001, 1002, 1003, 1004. When you start counting out to 5 or 6 seconds, that's a long time. And you should probably quit counting at some point and do something. But so we're looking for that. We're also looking for, are they cool or are they warm? We also then, we look at this leg of the triangle and we decide, is it normal or abnormal? If it's abnormal, we break it. So now I look at my whole triangle, and this helps me decide how sick is my child and how quick do I need to act. So it's a how sick, how quick. If I only have one abnormal on my triangle, my kid is not that sick. I'm not super concerned. If they're just having a lot of work of breathing, but they still have a normal appearance, their tickles are fine, and the circulation of the skin is good, what I have is a child in respiratory distress. That's why they came to see me today. If I have an abnormal appearance, they're kind of sleepy, laying against mom, a little lethargic. They're kind of tracking you around the room, but not a whole lot. They're a little bit flaccid, but their breathing is fine and the circulation to the skin is perfect. They probably have a fever. It's going to be my guess, or it's nap time. They're probably okay. Then, if I start to combine two, though, if I have an abnormal appearance and abnormal circulation to the skin, my child is sicker. In fact, this is early shock, appearance and circulation combined. Breathing and appearance is early respiratory failure. my kid's not able anymore with their respiratory distress to keep the normal perfusion to their brain and that sort of thing. So one system's affecting the other. And you'll see now they're pretty tachypnic, they're breathing, we did that too fast in our head, and now they're also not tracking, not watching mom. That's gonna be respiratory failure. When I get to the point that all three legs of this triangle are broken, I have a child by definition that's in shock. I need to be acting very, very quickly. Children do not sustain shock states for long periods of time. This is when they're about to jump off of your cliff. You don't even have to know what the underlying problem is. We need to find it pretty stinking quick to treat it. But this is when it tells us this child's in shock. And so you will see some pretty subtle, he just appears lethargic on mom's lap, not really tracking, slightly decreased tone. Capillary refill's like 4 seconds and his legs are a little mottled. And he's breathing, I don't know, he's 2 and he's breathing 28. Abnormal, the top, but he's got some retractions going on, and I hear this sound with every breath. That child's in shock, respiratory failure in shock. One system is affecting the other, is affecting the other. It's really a pretty nice way to think about assessing your child. So today when we do our practices, one of the first things I'm going to do is give you what you see from across the room. And you're in your mind going to say to yourself, how many legs of my triangle are broken? All right, the second component of our assessment is our A through E. Okay. We've all seen this mnemonic a million times. Airway. With each one of these, we're going to have assessments that we're going to make and then possible things that we can do to fix it. But right now, we're just going to focus on the assessment. So airway is first. And our airway only means that there's a patent tube from here to here. Doesn't mean air is going in and out. It means air can go in and out. I want to make sure that they're not having to sit to maintain it, or that I'm not having to do this to maintain an open airway. I'll never forget getting a 6-year-old. Mom comes carrying him into the triage desk. I was up there talking to the medic at the front desk, and she's just like, we just came from the dentist's office. They sedated him and pulled some teeth, and they said he was awake when they put him in the car, but he really wasn't. So they said if I just leaned back and held his chin up while I was driving him home, he'd be fine. He had a heart rate of 42 when we got into the resuscitation room. He was ashen and gray. His tickles, he didn't tickle. His circulation of the skin, his cap refill was at around 5 or 6 seconds. All we needed to do was bag him 3 or 4 times. His heart rate came back up. And then, of course, we watched him and tried to get a hold of the dentist to see what they gave, to see if we could reverse it. And they went to lunch and they were gone for the day, so then we filed all sorts of complaints. But literally, if you're having to help maintain that open, what's the most common cause of an airway obstruction in an unconscious patient? The tongue, right? So opening positioning is really important. Okay. After airway comes breathing. So for breathing at this point, this is where we actually, I know we just assessed breathing, right? You're all saying this to yourself. We just assessed that. But now we're really counting, because I can tell you, kids' vital signs change daily, right? I mean, what's normal for a 2-year-old is not normal for a 3-year-old, is not normal for a 6-year-old, is not normal for an infant. So I might find when I actually count that baby's respiratory rate that is 68, that's too fast. Looking at it, it didn't look all that impressively fast from across the room. So here I want an actual respiratory rate. I want a depth. Is it adequate depth? I want to now listen to lung sounds, right? So I want to listen for wheezes, crackles, anything like that. Rate, depth, lung sounds, and then also my skin color is important here. Okay.
What is the normal heart rate on an infant?
So if you look in your book, help me, page, I'm going to forget the page number. There is a table in the 70s, I think, that's going to give you all the normal vital signs. You're going to want to get familiar with it today, because you're going to be asked 2 or 3 questions later today about whether this is a normal finding. blood pressure, heart rate, temperature. I believe it's in the 70s. Jill's looking for it. She'll let us know as soon as she finds it. There's two of them, and they're about 2 pages apart. One of them is really in-depth, and the other one is very basic. We want the basic noise. Well, the in-depth one like gives you percentiles of everything. I thought it was in the 70s, Joe, but I might be wrong. It may be way at the it's in the assessment portion.
In the assessment portion? Well, under systematic approach, there's normal respiratory rates, and
There you go, 39.
39. So that's close to 70.
Yeah.
Respiratory rate.
Yeah. So that it is important because it's important to know what those vital signs are. In the pediatric emergency room, we actually
Well, that's just the respiratory rate.
That's what I wanted.
oh, you just there is one that's got the most.
The normal is what I wanted.
Yeah.
With
But
Page
this is just respiratory.
Yeah.
What?
13 is normal respiratory rate by age.
I'm looking for all of them. There's a
have
table
a
that's
different
got
book.
all of them. Heart rate.
That's 13 in my book.
Okay.
We'll find it on the break and I'll give it to you because you'll want it later today. Okay. So we want the rate depth, and we want to put them into normal, abnormal. In our pediatric ER, we post them at triage because none of us actually remember all the time exactly by age. And sometimes 28 is significant, and sometimes it's not. You know, in the adult world, if you wrote down 30 for respirations, you would be like, what's wrong with my patient? You wouldn't let that go by.
Oh, mine's older.
We can write down 30 in the pediatric ER 100 times a day and not think about it and then realize, oh, I just assessed a 15-year-old and I wrote down 30. There's a problem. I need to go and get my 13-year-old.
Yeah.
So it's important to actually count. So then after breathing comes circulation. Circulation is assessed differently in children than it is in adult, right? What do I want to know in circulation? I want to know my cap refill. Good. What else?
Color.
I'm sorry?
Color.
Yeah, I want to know skin color. I'm looking for things like modeling. What else?
Want to know if it's central or peripheral.
Central and peripheral, that's an important one. How many times in your adult patients have you laid them down and compared their femoral pulse to their pedal pulse? What would be the purpose of that? Other than maybe left to right, like do I have a big old artery that's not functioning on one side, but we don't compare. In children, we compare. You will lose their peripheral pulse completely while they still have a great blood pressure and a great central pulse because they are so good at compensating that they've clamped down. I've seen severe trauma patients that we had a 10-year-old that was SUV versus 10-year-old versus park wall. So there's a giant round wall, like when you enter into the park, made of brick with the title of the park on it. She was walking across that street when the SUV veered off the road, pinned her between the two. She got to the ER. Her blood pressure was in the 150s. Her heart rate was in the 180s. Abnormal and abnormal. She didn't have single peripheral pulse at all because she was so clamped down. She was in shock, flagrant shock. We kept asking for fluids, and our trauma surgeon kept saying, she's got a great blood pressure. And then when she crashed, he's like, get the fluid. But, you know, he asked later when we did the debrief on that particular trauma, he's like, what clues were there? We kept telling you she didn't have a peripheral pulse. He said, I kept hearing that, but I didn't. What does that mean? It means that that's how she's maintaining that 150 blood pressure. That's why she has a 150 blood pressure. She's extremely constricted. So think about your actual heart rate. So we want the heart rate. And we also do want a blood pressure in our critically ill children. Blood pressure is not our guiding factor, but it's still important. We want to know that it is normal for age. So we're going to compare central peripheral pulses. We're going to get a good blood pressure. And then we also want them on the cardiac monitor. Cardiac monitors are boring in the pediatric world, you guys. They don't do anything fun or fancy. Rarely do they do something fun or fancy. When they do something fun or fancy, you're like, whoa. But it does tell you a lot, sinus tach, or can tell you maybe that they're in SVT or something like that. So that's what we assess in circulation. What does D stand for in this mnemonic?
Disability.
Disability, what does that mean? Do they have cerebral palsy? Do they walk with a walker? Is their IQ above 60? What does disability mean? And why are we assessing it here in a primary survey?
You want to know if there's something like grossly wrong.
Yeah, exactly. What we are actually assessing here, and this helps you grade, if not keep on with your disability. I'm assessing the brain. Is the brain getting enough blood flow? That's what I want to know. Because a child who's not getting enough cerebral perfusion is going to be having problems. So I'm assessing right now, do they get enough blood flow to the brain? Has the brain got a problem? Or did they have a big old head injury? Or did somebody shake them? Those are all those kinds of things I'm looking for. In PALS, we use a mnemonic to tell us how with it our child is very quickly. AVPU, this is information that will be important later today. So if it's A, they're alert, they're awake. So if I asked you, if you have a 6-year-old patient who is alert, following commands, making eye contact with you, he would be A, alert, awake. V stands for voice. They wake up to voice, okay? Sometimes it's loud voice. P stands for pain. They only wake up to pain. All of us ER people, right? We do this all the time to everybody, or pinched inside of the little arm or whatever. And then U stands for ooh. Ooh, they don't wake up at all. They're unresponsive, okay? A decreased level of consciousness is something in a child that requires immediate action. If you have a decreased level of consciousness, it requires immediate action. Did I say that twice? Because if I say it 3 times, you may see it again later. Requiring immediate action would be a child who has a decreased level of consciousness. And then the last one in this segment of our assessment is to expose, examine, and unlike the adult world, we also ask about exposure, which sounds like this. Has he been around anybody sick lately? Does he have a fever? So we're looking for infectious processes. But expose and examine, uncover that kid. We were under construction several years ago in our ER, and I had a little 24-month-old that we had triage bays that we were using them as rooms because they had taken a big section of our rooms away for construction. And it wasn't very good lighting, and they were tiny little, I wish you could see them, they look like a pie wedge. And you're in there with a bed, and you can barely move around it. We were seeing 350 kids a day in 13 beds. We were just getting killed. But I was in there, and I started looking at the kids. There was something just not right. Her tickles were not good. Her work of breathing was maybe a little bit decreased. Her circulation to the skin still looked okay. So I was concerned about her, and I started doing the ABCD, and I get to the exposing them. She wasn't resisting me as much as that she should have. And so I started taking her clothes off, and I'm like, that's a strange shade. And I had already decided I was going to put an IV in her because she just wasn't interactive enough. And so I had the IV tray, and I took an alcohol prep, and I was just looking at her little hand, and the more I rubbed, the browner the alcohol pad got, and the paler her skin got. So I took the alcohol pad and I rubbed it across her abdomen. Same thing. And this mom says, oh yeah, she got into my makeup. Could y'all clean out room 3 for me? I need better lighting. She was completely covered in makeup to cover all of the bruises that she had from her chin all the way to her feet. Her little splenic lac that you could literally see the bleed into her abdomen. So expose and examine in our kids is important, because I have yet to have a parent walk in and say, I shook him, that's the problem. They don't say that. I don't know, she just went unconscious, her eyes rolled back in her head in the bathtub. They're always in the bathtub in the shower. I've never figured that out. But then you start exposing and examining, and there's thumb bruises right here, and finger bruises back here, or bruises right here. So exposing and examining is a really important part of figuring out what's going on with our kids. Okay? So, airway, breathing, circulation, what's going on with the brain, and is there anything else I haven't seen? The other thing you can find in a kid when you uncover them is some nasty rash that might make us all act differently in a few minutes, like put on gowns and gloves and masks and call the cleaning crew for the bed bugs or whatever else it is that we have, right? So, okay. So the third element of our assessment is getting a focused history. History is important in the kids. We don't really like to take them away from their parents a whole lot because we need to know what's going on. And I have yet to have a 2-year-old tell me what's going on. So I need with mom. You can take the history on a child. There are several different mnemonics that you can use. If you've been through ENPC, then you've seen CIMPEDS, which has got a little bit different. We use sample in PALS, and sample's going to help guide our treatment. That's why we do it. If we don't know why, I might know the whole triangle's broken, but if I can't figure out why, then I'm not going to be able to aim my therapy the right place. Okay? So that's why we do the sample. What does S stand for? Anybody, pre-hospital people know this?
Signs and symptoms.
Signs and symptoms. So this is our signs and symptoms. A stands for
Allergies.
allergies. M stands for
Medications.
medications. P stands for
Past medical history.
past medical history.
Past
L,
oral intake.
last intake. Somebody back there's got it going on. And E, the
Everything
events
else.
leading up. Okay? Every one of those is important, and when you're taking them, they sound redundant. You're like, why do I go through all of them? So, the tale of two 18-year-olds. Signs and symptoms. My baby's having problems breathing. Okay? Same. Allergies. Neither of them have allergies. Meds. Neither of them take any medications. Past medical history. Both of them are previously healthy. The last oral intake. 18-month-old number 1 has been not eating well for 3 days, but has been drinking fine. Last oral intake for 18-month-old number 2 was this morning at breakfast. It's now 4 o'clock in the afternoon. Was lunch. It's now 4 o'clock in the afternoon. So, ate fine. Okay. Events leading up to it. Okay. 18-month-old number 1 has had cough and cold symptoms, runny nose for 35 days and a low-grade fever, and then started this funny cough this afternoon. 18-month-old number 2 is making the same noise. I found him in the 5-year-old's room playing with Legos. Those are the events leading up to it. Am I going to treat him the same? How much racemic epi am I going to give number 2?
None.
Who am I calling for number 2? A surgeon with a rigid bronchoscopy, right? I'm going to get moving on that because that's important. So this whole thing tells you a lot. 18-month-old number 3 was having problems breathing, has a severe peanut allergy, has an EpiPen at home for it, no other history but the peanut allergy. He was at the neighbor's who gave him a granola bar. Okay. So the last oral intake and the events both came together there, but we're going to treat him even differently. He's making the same noise, believe it or not, but he's wheezing on the expiration. So really important that we get a history, especially when you just get handed an unconscious kid. Mom and Daddy, what's been going on the last few days? Is he allergic to anything? Does he take anything? With parents and children, it's the same with adults, but I think it's a little bit worse with children. You have to ask that question several ways and several times. Does she have any medical history? No. Does she have any medical history? No. Does she have any medical history? No. Okay. We did this one day. We had a forfer, and everybody who's ever worked in the ER knows that the more of you that come in from the same family at the same time, the less sick you are, and the less we want to see you in the ER, right? Because nobody gets a deathly illness, all 4 of you at the exact same moment. So we had a fast track and we had a main ER, and so this is like 3 in the afternoon. Fast track is open. There is no reason to see conjunctivitis in the main ER. And if you don't believe that, ask the ER doctor. He'll let you know in no uncertain terms that belongs in fast track. But we had all 4 of them were in the room, and she comes out to me, the ER doctor, and she's like, please tell me why I'm seeing conjunctivitis at 4 in the afternoon. Tell me there are 80 kids stacked up over in fast track. I'm like, no, they're empty. She's like, then why am I seeing them? I don't know. Went to triage nurse and talked to her, and she's like, well, because of the liver transplant. We go back and talk to Mom, and sure enough, we had asked several times, do any of them have any medical history? No. The nurse had seen it on the computer when she brought it up. So, well, yeah, liver transplant with an infectious process is going to stay in the main ER because it's not as straightforward. The ER doc was just like, Mama, I asked you if she'd ever had surgery much. She said, yeah, you did. Well, they did. Well, why did she have to have a liver transplant? And I swear this is what she said. She said, I don't know, we just came in one day and they changed it out. So, you and I all know that she never got all the way to liver transplant without some education sitting down. This is why we're transplanting your baby's liver. Okay. So this is our 3 segments of assessment. that we're gonna go through. And then when we get here, we're gonna hopefully have a clue as to what's going on with our baby and how to treat it. When we start to treat, we're gonna treat right as we go down this part. In the real world, these three things all happen at once. This thing happened at the front desk when I walked in with my baby and you made your assessments. We started looking at this as we walked back to the resuscitation room because my triangle was broken. And then we start asking these questions. They all happen at once. We have a whole team of people that come. How many times you work a sick kid all by yourself in the ER? Not a sick one. The team is all right there. But when you're the person responsible, if you will go in this order in your head and make sure you have done every one of these assessments, then when you get done, you will have all the information that you need. Any questions about initial assessment or the organized system? In this area, if we find a problem, we have to fix it before we move on. There's no sense in breathing for a child who doesn't have an airway. The only time it's completely different if they're pulseless, and then we start here, right, with compressions. Okay. What we're going to do now is we're going to watch a shorter video where we actually are going to see some children, and we're going to, just 3, and we're going to apply our tickles to them. We're going to say what they, we're going to use tickles and decide how sick, how quick. Would you mind getting my lights? Thank you.
Welcome to the Pediatric Systematic Assessment video. In this course, we'll focus on evaluating your patient, identifying the presenting problem, and providing appropriate interventions. Once interventions have been performed, repeat the process by reevaluating the patient and identifying if the problem has resolved or worsened. Then apply additional interventions as appropriate. The first step in the systematic approach is the initial impression. It's what you first see and hear when you immediately encounter the child before you touch the child. You'll quickly observe the child's appearance, breathing, and circulation. This will determine your next actions. The Pediatric Assessment Triangle, or PAT, is a memory aid to help you recall the components of the initial across-the-room assessment.
The first thing you'll observe is the child's appearance. This includes his level of consciousness and ability to interact. If the child's unresponsive, you should shout for nearby help and then activate the emergency response system. Then you should check breathing, pulse, and provide rescue breathing or CPR if needed. The next part of the pediatric assessment triangle is evaluation of work of breathing. Is there an increase or decrease in rate or effort? Is it normal? Or are there audible respiratory symptoms? After breathing, you want to look at circulation, which will tell you how well the child is perfusing. This includes skin color and pattern or obvious significant bleeding. Always remember, it's a life-threatening condition if the child is unresponsive or apneic, has inadequate or labored breathing, or is mottled, gray, pale, or cyanotic. You want to immediately call for help and begin life-saving.
Talk to me about her tickles. What's her tone?
She looks kind of limp.
She's kind of flaccid. All right. Interactivity. She looks like she's about 14 months old, somewhere between 10 and 14 months old. She's got tubes and wires coming from everywhere. She interacting appropriately with that. Consolability, she's almost a little too consoled. I'm a little concerned about that. Her look, she's looking at something. I'm going to guess mom or a toy or something since they're filming. Speech, she's not got any. She's able to take the passing, which is telling me something a little bit about her work of breathing. Okay. So then her work of breathing?
She's labored.
Yeah, she's labored. She's got retractions. Remember what I said? The higher they are, the greater the work of breathing. She's got tugging up here at her trachea, and she's got some nasal flaring going on. And what about her circulation of skin? Kind of hard to tell because we don't get to touch her. But she's really flushed up here. She's kind of pale out here in her perimeter, right? If you look real closely, it's hard to tell. On the computer screen you can see it, but that thigh's a little bit mottled. So modeling in and of itself could just be a cold red-headed child. But modeling in, I have a son who, if you treated him every time he was modeled, you would live your life trying to resuscitate him because he's always modeled. But it can also, in conjunction with this full picture, modeling is much more concerning to me. My guess is her cat refill's right around 3 or 4. I mean, it's probably high normal to low abnormal. Okay. Other than cute, what are his tickles? He looks great, right? Tone, interactivity, consolability, yeah. His work of breathing, we can't really tell without lifting his shirt, but looks like he's doing okay to me. And his circulation of the skin is normal for his ethnicity. So, am I worried about this kid? Is he a sick kid? No. He can go back to the waiting room until next Tuesday, because that's probably when we're going to have time to see him. We do a lot of just, hey mama, just lift his shirt so we can see those retractions if they're there, because that would let us know we need to recheck him a little more frequently than next Tuesday. Maybe we'll look at him on Monday afternoon, but he looks great. All right, last one. Talk to me about her tickles. She's making a cute little noise. It's not so cute at all. That's in a work of breathing, yeah. Her tickles, so she's, to be working that hard to breathe, the fact that she's not awake and anxious and fighting with me, she's flaccid, right? Interactivity, she ain't. Again, if I'm working that hard to breathe, I'm going to be awake getting my air and my oxygen. Consolability, again, way too consoled. Look, maybe she's asleep, but I'm not really going with sleep. And that wonderful noise she's making. So work of breathing, did you see her tugging here? She's really tugging. Yeah, so her work of breathing is pretty high. She's making that cute little noise.
Open her.
That cute little noise is stridor. We don't like that little noise, especially not at rest. Stridor's okay in a kid with croup who's running around crazy, but if they're sitting still making that noise. And what about her circulation to the skin? What color is that? Gray, yeah, it's just a beautiful shade of gray, which is not in any textbook as far as an okay color. So is she sick? How sick, how quick do we need to deal with her?
Immediately.
So if I was at the front desk with this kiddo, I'd be picking her up and I'd be running to the resuscitation room. You know what I might find out? I might find out she's just poorly positioned in her chart parcel. But I would rather find that out in the resuscitation room than try that at the front desk and find out that that's not the problem, that her heart rate's 20 and she's fixing a code. I want to sort that out in my resuscitation room, not at my front desk. Yeah, I'm going to guess there's a little more going on than just malposition, but it could be. All right, so everybody kind of sees how tickles gets applied, and then we move on to a full assessment of airway, breathing, circulation, expose and examine. All right, it is time for a, how are we doing here? Let's come back at quarter till. I need a little bit of a break. I'll find those abnormal vital signs during this break and make sure that I put the page number. Experienced intubator that we have. We are not messing. Same way really with foreign body. They have sort of a do not disturb sign. We have all sorts of federal regulations in a helicopter about how people get strapped in. I tell you what, that 18-month-old, she just rode in Grandma's arms just like she was on that ER cot. She didn't get strapped anyway at all. So it's really important that we do not disturb these patients. We really want to watch out with upper airway obstruction because it can get worse. So we treat them with do not disturb signs. I took a little 4-year-old who aspirated an Indian teardrop, which is a stone that they use, the one that's shaped like a teardrop on like a necklace. It was the cutest little thing, and his x-ray was right at his carina. But he wanted to lay on his left side, just not the right side in the helicopter because I can't see his face. Because when he laid on his right, it occluded his right mainstem bronchi. Now he could still breathe, but he knew he wasn't getting enough air. Laid on his left side. He sort of got a seatbelt kind of thrown over him a little bit. Because our helicopter crash wasn't my biggest concern. My biggest concern was that he breathed all the way to where we were taking him, which was an hour flight. So These are do not disturb signs. How do we treat anaphylaxis?
Happy.
Epi, yes. How do they get their epi?
I am.
IM, yes. They get IM epi. What else do they get?
Pepsid, Benadryl.
Pepsid, Benadryl, so histamine blockers. Okay, and I heard steroids, yes. Most specifically, they're going to get something like Solubenadryl. And I heard the Pepsid, the Benadryl. I feel like I'm missing one. Oh, we'll do breathing treatments for them too sometimes just to try to open up. But so that's how we treat anaphylaxis. Trauma is going to be dependent on what is going on specifically, but maybe suctioning, just maybe if they've got a big bleeder or something in the back of their, it's not exactly trauma, but post-tonsillectomy. There's a lot of bleeding sometimes in the back of their throat. How do we treat croup?
Racemic epi?
Racemic epi. That's an important piece of information. So that's kind of the first line. If I have a child who's stridulous at rest, I'm going to give them racemic epinephrine. So nebulized, and it doesn't have to be racemic, nebulized epinephrine. Okay? What else do we give them? We do, humidified O2 or humidified air. That's right. In fact, we do a lot of just saline treatments where we just let them cool mist, we call it.
Steroids?
Steroids, yeah. The specific steroid this time, it's a single dose.
Dexamethasone?
Yeah, dexamethasone, Decadron. A little tip if you have to give a child Decadron that is already got an air obstruction. If you've got a kid who's stridulous at rest, is really giving you problems, they do not want to take, dose of Decadron is 0.8 milligrams per kilogram, which for a 3-year-old is about, feels like about this much. And they're already gagging on everything you give them. We take the IV preparation of Decadron. You can get